Okay, good morning everyone, and thank you AIOS for giving us this opportunity to conduct this instruction course on behalf of JAS. I'm talking on electrooculogram tips. So who is credited with the first description of the EOG? The EOG was first described by Elvin Mark and clinical applications were described first by Geoffrey Arden. So the principle, huh? Our IC is still 1025. You can take as much knowledge from Dr. Purna and Dr. Rahul, Dr. Nidhi, Dr. Vibhuti Bhushan, as much as you can. So physiology behind EOG is that during the 15 minutes period of dark adaptation, there is a fall in the recorded standing potential, typically reaching a minimum at 10 minutes, and this is referred to as the dark trough. And following light onset, there is an increase in the transepithelial potential of RP producing the light rise. The light rise is ultimately the result of increase in intracellular free calcium, which is released from the endoplasmic reticulum, regulated by an interaction between ER bestotrophin and L type of calcium channels associated with basolateral membrane. The intracellular calcium gates the opening of a basolateral calcium-dependent chloride channel. Increased chloride conductance depolarizes the basolateral membrane, which increases the transepithelial potential, recorded as increase in the standing potential of the eye. So what are the prerequisite and instructions? The prerequisite is dilated pupil, pre-test 20 minutes normal room light adaptation, full extraocular muscle motility, good visual acuity, refraction correction is not needed, impedance should be less than 5 kilo ohm. The head position should be stable, eye movement only in horizontal direction, never anticipate and move prior, increase illumination in case of the non-dilating pupil, and avoid any bright light procedure before EOG. So stimulator is the Gangefield dome, how it is performed. The two LED lights are 15-degree left and right of the central light, and it is bright during light adaptation, and minimum brightness is maintained in the dark. The pupil should be dilated before testing, and after suitable skin preparation, recording electrodes should be placed close to the canthi of the HI. For the dark phase, total darkness should be maintained for 15 minutes except for the dim fixation light. For the light phase, a Gangefield background light of 100 photopic candela square meter should be turned on, and continue the recording for 10 seconds out of every minute in each phase. Active, you can see the active and reference electrode, inner and outer canthi, ground electrode forehead, and impedance should be less than 5 kilo ohm. You can see here gold cup electrodes, black is the ground, blue is the reference, and red is the active electrode. The patient has to move his eyes to LED with single sweep with head fixed. Sackets recorded 10 to 15 seconds per minute, 40 to 45 to 50 seconds rest. Measure 15 minutes in dark and 15 minutes in light. RN ratio is the maximum amplitude in dark light adaptation and minimum amplitude in the dark adaptation. LP by DT is into 100 is more than 180. If it is less than 1.65, it is abnormally low. So parameters, what are the parameters which should be included in the EOG report? LP by DT ratio, DT amplitude in microvolt, implicit time, time from the start of the light phase to the light peak, type of adapting light source, pupil size, and note on any difficulties encountered during testing which may affect the confidence in results such as inconsistent eye movement. So the reliable EOG is square regularly placed waveforms. Waves are not that proper, that means either patient is not fixating properly or electrode is moving. Light and dark values taken in respective adaptation period, typically 12 minutes for dark trough and 25 to 26 minutes for light peak. Background illumination is 100 candela per square meter. So the normal light rise in EOG requires a normal RPE and good photoreceptor function. As the light rise depends on the photoreceptor function, also the patient with abnormal rod function will have a corresponding decrease in the light rise, thus mirroring the extent of rod photoreceptor damage. If ERG is absolutely negative, the EOG will be absolutely negative too. Some photoreceptor action is must to have an EOG reading, so we recommend always to do ERG and EOG together and not in a singular form. A bit in case of good rod function in ERG, a reduction in the light rise in EOG is suggestive of abnormalities localized to RPE, that is the best disease. Now I'm sharing few clinical tips. The most common use of the EOG is to confirm vitelliform macular dystrophy, patient with Best disease and some patients with adult vitelliform dystrophy, where we have normal ERG but abnormal EOG. You can see here the LP by DT is 1.33. So in bestrophin gene mutated dystrophies, if you see, in all EOG is reduced only in adult onset vitelliform macular dystrophy, it is normal. And if you see ERG is normal in all bestrophin gene mutated dystrophies, only severely reduced in autosomal dominant vitreoretinochoroidopathy. Now, EOG is abnormal irrespective of the stage of best vitelliform dystrophy. If it is a case of unilateral clinical best dystrophy having but then it will have suboptimal Arden ratio in both the eyes. And if EOG in a child with suspected best disease is difficult to perform, test both the parents, as one carrier parent will surely exhibit abnormal EOG. So test the parents. And there is a debatable role in differential diagnosis of congenital stationary night blindness. EOG is actually useful in differentiating CS and B, in which it is normal from other progressive progressive disorders causing night blindness. It is also abnormal in photoreceptor-led disorders, Stargardt's disease, retinitis pigmentosa, cone dystrophy, and cone rod dystrophy. What is fast oscillation EOG? In 2017, the ICEP standards for clinical EOG included fast oscillation EOG officially. The advantage of fast oscillations is that the test time is shorter, making it easier for the patients to be tested. The slow oscillation is recorded over 15 minutes of dark adaptation followed by 15 minutes of light adaptation. On the other hand, the fast oscillation has the advantage of greater compliance because of the total inspection time is only 15 minutes. Fast oscillation is different from typical EOG, which is dependent on the calcium gated chloride channel. These are sinusoidal, they are not typically square, and the alteration takes place in 1 minute interval in fast oscillation pattern of waveform, and mechanism is also different from typical square. It is happening at the apex of the RPE, not at the base of RPE, and the fall in subretinal potassium reduces the movement of chloride into the RPE. The resulting hyperpolarization is responsible for the light trough, not the peak, and followed by dark peak, not the dark trough during recovery. And here apex is having different potential changes. So role in distinguishing whether CSC is the acute or chronic type by evaluating RPE function, as patients sometimes don't know the exact duration of the disease. In chronic CSC, decreasing RPE function is confirmed by decrease in the amplitude of the light trough. Remember, light trough, not the light peak of fast oscillation EOG. These parameters can be used as indicators for detecting the severity of macular functional disturbance and predicting the visual outcome for this entity. Thank you so much. I hope you are now aware of EOG and practical applications. Thank you.